I'm Fran Smith. I'm an independent journalist, a writer, an editor, and a contributing editor for the USC Center for Health Journalism. Thank you for joining us today for our Health Matters webinar covering coronavirus unequal access to treatments. Today, we'll look at COVID therapeutics and barriers that prevent them from getting to people who need them most. We'll also highlight reporting tips and key stories to track. Before we get started, we have a room filled with journalists, so I need to mention that the Center for Health Journalism is right now conducting a call for applications for our July National Fellowship. It provides training, reporting grants of $2,000 to $10,000, and mentoring for journalists with a project on children, youth, and families they've always wanted to tackle. Our core focus is health equity, and to learn more, email us at editor@centerforhealthjournalism.org or look for more information in the chat today. Now on to COVID treatments. New COVID drugs are remarkably effective in preventing hospitalization and death, but getting them to patients in the crucial first days of infection is a huge challenge, especially in our fractured healthcare system. CDC research has shown that patients of color are less likely to receive potentially life-saving monoclonal antibody treatment than white patients, even though they're at higher risk of dying. The White House is rolling out the Test to Treat program to speed up delivery of antivirals. At the same time, Congress has denied the administration's request for $2.25 billion in COVID funding, and the White House says it's running out of money for monoclonal antibodies, antivirals, and other COVID strategies. COVID cases are down here right now, but increasing in Europe and surging in Asia. Will we get caught on our heels again? I'm really excited and honored to introduce three amazing panelists to help us explore the landscape of COVID therapeutics and stories going forward. Dr. Aaron Carroll is a distinguished professor of pediatrics and chief health officer at Indiana University. He's also the host of the YouTube series Healthcare Triage and editor-in-chief of the Incidental Economist blog and a longtime contributor to the New York Times. Dr. Carroll's research focuses on the study of information technology to improve pediatric care, decision analysis, cost effectiveness of care, and financing reform. He's the author of The Bad Food Bible and co-authored 3 other books on medical myths. He earned his MD from University of Pennsylvania School of Medicine and an MS in Health Services from the University of Washington School of Public Health. Daniel Chang covers healthcare for the Miami Herald, where he focuses on health insurance, hospitals, and health policy. He was a 2014 National Health Journalism Fellow at the USC Center for Health Journalism and now serves as a member of the Center's advisory board. Daniel Chang began his journalism career in 1995 at the Orange County Register. He's been a reporter at the Herald since 2000. And Dr. Annie Lutkemeyer is a professor of medicine specializing in HIV, infectious diseases, and global medicine at UC San Francisco. She's a primary care doctor serving patients with HIV and COVID and leads clinical studies in HIV, hepatitis, and now researching novel therapeutics and preventative strategies for COVID, including antivirals, anti-inflammatories, and vaccines. Dr. Lutkemeyer earned her MD from Harvard Medical School and trained in internal medicine, clinical research, and infectious diseases at UCSF. This webinar is made possible thanks to generous support from the Commonwealth Fund, the National Institute for Healthcare Management Foundation, the California Endowment, and individual supporters like you. You can tweet about the webinar with the hashtag Unequal Access. We'll be archiving this conversation later today at centerforhealthjournalism.org. And a word about our format. We'll hear from our speakers first, and then we'll turn it over to our audience for your questions. Feel free to share general comments in the chat, but because we have so many people joining us on Zoom, we'd ask you to write your questions for our speakers into the Q&A panel. You can also write to us there if you're experiencing technical problems. So now let's turn to COVID-19 therapeutics. Dr. Annie Lukemeyer, to lay the foundation for the conversation, please give us a brief overview of the available medications. What's out there, what are they used for, and what are the key safety considerations?
Terrific. Well, thank you so much for including me here. And I'm just pulling up my slides and hopefully getting them into the right presenter view. Does this look right?
Yeah.
Terrific. So I just wanted to give a very brief overview of what we have available here. It's a very exciting time because we finally do have effective oral antiviral agents. Our job is going to be then getting these agents to the people who really need them. So just a reminder of what we're trying to do here, why we have this focus on outpatient COVID treatment when for so long we didn't have this. Well, the hope with most of our therapeutics is to reduce the risk of hospitalization and death. But we also want to reduce symptom duration. When people, even though they're called mild COVID, we know that they can feel very unwell. COVID can be a tough disease, even when it's outpatient. So being able to provide some symptom relief and reduce symptom duration is very welcomed. And then we know that many of the COVID outpatient therapeutics can reduce the viral load. So this raises the possibility that this might reduce transmission to others. So who should we currently be thinking about for providing outpatient COVID treatment? Well, right now, the emergency use authorization indicates that we should be giving it to people who are currently symptomatic and have a COVID test that's positive. A home test is fine. And we're trying to really target people who have one or more risk factors for disease progression. This includes people who are unvaccinated or undervaccinated, those who are over the age of 65, and people who are immunocompromised or who have other risk factors, such as diabetes, heart disease. And I'll share a little bit more about this on the next slide. When do we treat them? This is really critical. For oral therapy, you need to start within 5 days of symptom onset, and sooner is better. Some of the studies even looked at starting people within 3 days of symptom onset, and that creates a bit of a logistic challenge. So we want to, as closely as we can, tie a diagnosis of COVID to thinking about, should this person be treated and how can we do that? Monoclonal antibodies, which we'll talk about more in a minute, which are given typically as infusions or injections, should also be given as soon as possible, but the window is extended to 7 days. It used to be 10 days, but now it's been reduced to 7 days based on the available data that we have. And just a reminder that COVID treatment, however people are treated, is not a substitute for vaccination, and it is not a substitute for appropriate isolation during the infectious period, even if you're on effective therapy. Right now, we don't have data to support that if we treat someone that they can go back to work or be in then potentially infectious environment sooner. I just want to remind you all of some excellent resources that are out there. There's the NIH has a COVID treatment guidelines. IDSA has COVID treatment guidelines as well. I'm just focusing on the NIH treatment guidelines here right now, and here's a link. And they have provided a tier system for those to help prioritize whom we should be treating with oral medications by this tier. And my point with this, now that we are out of the big surge and we have more access, is that people who are vaccinated with symptomatic COVID qualify for therapy. So while I think for a while we were thinking about, oh gosh, those are tier 4 patients, and the message on the street for many people has been, oh, I don't qualify for therapy. Really, many people do qualify. They need to be symptomatic within 5 days and then have one or more risk factors. And that includes things like diabetes, heart disease, lung disease, obesity, pregnancy, and even just being over the age of 65. So I think we need to think about this more than we have in the past. And the good news is that we are out of a big surge environment and we have more drug supply. So just a brief overview of what these drugs do, and then we'll talk about how they work and then get into some discussion with the panel. So this is just a cartoon of the SARS-CoV-2 antiviral life cycle. Hopefully you can see my pointer here. Here's the virus coming into a cell and emptying its contents that then gets translated into this polyprotein chain that gets chopped up by a protease and then turned into new pieces using this RNA replication polymerase. then new copies are made and they are packaged and sent out of the cell. That's a very oversimplified view of the life of a virus, but its job is to get inside of a cell and then to make copies of itself. Our current agents help to block this life cycle. So the anti-spike antibodies, and the ones we currently use are sotrovimab and the most recently approved bebtelovimab, block the virus from even getting into the cell by blocking the spike there. And I've just included the date of FDA authorization to help remind us of how far we've come. The protease inhibitors, and the one we're most familiar with right now is Pexlobin, that was approved in December, blocks this protease inhibitor step where this polyprotein chain is broken up. We have agents that directly target this RNA replication. Molnupiravir is an oral medicine that targets this RNA-dependent RNA polymerase. And then remdesivir, which we're familiar with from the inpatient setting, has also now been approved as an outpatient IV therapy given over 3 days, which is a little bit unwieldy, but really excellent data to support the use when people can access it. So I wanted to then just conclude by providing sort of an outpatient treatment option framework and talk about some of the pros and cons of each of these medications. I'm going to start by talking about the pills, then we'll talk about the injectable or IV agents, and then I'll conclude by just showing you the NIH treatment guidelines framework, and we can have some discussion. So starting with Pexlobin, which is nirmatrelvir ritonavir, this is 5 pills given twice a day over 5 days. So something to be aware of for people if taking a large number of pills is going to be problematic. In terms of efficacy, this drug has worked quite well, shown an 85% risk reduction in hospitalization or death, which is an absolute risk reduction of about 5.5%. As I mentioned, it has to be given early, so within 5 days of symptom onset. And some of the important things that we think about when we're prescribing Paxlovid are what the other comorbidities are. So we have to dose adjust it if people have kidney disease, and we can't give it if they have severe liver disease. It can be given in pregnancy, although the data are limited. And really the big kicker with Paxlovid is that you have to evaluate someone for drug-drug interactions because of the both the nirmatrelvir and the ritonavir can interact. It can often be given with other medications. It just, this additional step needs to be taken to ensure that it can be done safely. The other all-oral agent that we have is molnupiravir. Again, this targets the RNA polymerase. It's also quite a number of pills. So it's 4 pills twice a day given for 5 days as well. It's been slightly less effective, and these are not head-to-head comparisons. The licensure study showed a 30% relative risk reduction in hospitalization, although there was recent abstract presented at an HIV meeting from data in India showing up to a 65% relative risk reduction, and an absolute risk reduction that's a little bit lower of 2.8 to 2.9%. Also has to be given within 5 days of symptom onset. Now, in contrast, while the efficacy is lower, there are no drug-drug interactions, and this medication is okay to give in people even if they have kidney failure or severe liver disease. One of the important considerations here, besides the fact that it has a slightly lower efficacy, which I think is certainly important to keep in mind, is that this medication is not recommended in pregnancy and in breastfeeding due to concerns about possible teratogenicity. It's also not recommended for children under the age of 18, and men are advised to use a barrier form of birth control for up to 3 months after using this medication, again, until we learn more about potential impacts on reproduction. So moving then to the IV or injectable medications that we have, and I've just lumped them together as COVID antibodies because these are, we've had a number of different agents, starting with the Regeneron antibodies that we heard a lot about in the beginning. There are COVID antibodies that are used for prevention, but I'm not including those here. So the ones that we have currently available and recommended are sotrovimab and bebtelovimab. And they have activity against Omicron, but there's been some questions around the BA.2 strain, particularly with sotrovimab. They, similar to Paxlovid, have quite a robust reduction in hospitalization and death, been shown to be about 85%, can be given up to 7 days after symptom onset. They do require a medical setting of some sort for administration, although there are a lot of interesting projects that have used medical vans to bring these to people's homes. Those are not widely available, but certainly is a way to make these medications more accessible. They've generally been pretty well tolerated. They don't have drug-drug interactions of concern, but they do require that you be monitored for about an hour after being administered. And then lastly, I mentioned outpatient remdesivir, which now has gotten an emergency use authorization. This is a once daily IV infusion that has to be given over 3 days. Similarly strong efficacy, so an 87% reduction in hospitalization and death, can be given up to 7 days from symptom onset. Pretty limited in terms of drug-drug interactions and limited concerns around kidney disease and severe liver disease. But again, as I mentioned, you have to have the ability to provide an IV, and this usually comes with a nursing facility or some sort of an inpatient or peri-medical setting. So I want to just conclude with the NIH treatment guidelines, current panel recommendations of how to prioritize these medications. And they have suggested this order based on efficacy and convenience of use. So prioritizing Paxlovid, and then sotrovimab, the monoclonal antibody, and remdesivir, followed by molnupiravir. And then I added on, and this is from the website, bebtelovimab, with a recent update that they've provided. And they've put this as fifth because of limited data, clinical data for use, although I think this is going to be changing. I think in reality, what many clinicians do is they look at the patient and they look at their available resources and figure out what the best fit is. And we don't tend to go right in order, but we figure out what we can do for our patient and how we can make these systems work. So I will go ahead and just stop by reminding everyone that there is a Therapeutics Locator that's available. This is the link. And this actually gets into quite granular detail. So we'll go down to, if you provide a zip code, it can tell you at a specific pharmacy what agents are available, or at a healthcare center. And I think this is a really nice resource to be available, to be aware of. And I will go ahead and stop there and turn it over to Fran to help lead the discussion.
Thank you, Annie, for that wonderful and really helpful overview. So when President Biden announced Test to Treat, he said he was doing it, quote, so people can get tested at a pharmacy, and if they're positive, receive antiviral pills on the spot at no cost. Dr. Aaron Carroll, is it that simple?
Unfortunately, it's not. There's so many problems with the way we treat COVID, but it's important to understand that some of them are baked into the cake of the healthcare system, which is already set up to make things as difficult as possible. So in order to actually make these work, as was just described, first of all, you have to be able to test and know that you have COVID. For some people, that's very easy. If you have a stockpile of antigen tests in your house or you've gotten them, that's fine. But in previous weeks, it was very difficult to find antigen tests, and it's been even more and more difficult to get tested in general as lots of states start to ramp down their testing facilities. But if you manage to get tested and you manage to get the results back in a day or two, which is also not guaranteed, you can at the moment get this drug without a prescription. So you would need a doctor's to get a doctor to write one. Many doctors won't without a visit. It was difficult to get a same-day visit or next day visit in the United States before the pandemic. It's only become more difficult now. The Biden administration, if they actually implement this policy, would allow for pharmacies that have minute clinics or on-site clinics to then actually see and write the prescription, but lots of pharmacies don't have that. Of course, lots of pharmacies in different in better resource settings are more likely to have those kinds of facilities than in less resource settings. And if all of that turns out to be true, and even if you manage to get a prescription, you got to find the drug at your pharmacy. And there have been shortages. And unless you have hours in the day with nothing to do, to be on standby, to call pharmacies, to know when they might be supplied, the likelihood of you getting this drug within 5 days of your being infected with COVID becomes less and less true. Of course, for those with means and those who know how to work the healthcare system, it'll probably work out fine. I know lots of people who've managed to do so, but almost all of them come from positions of means or where things are easier to do. In many ways, COVID has exposed and exacerbated a lot of the healthcare disparities we see throughout the United States. This has only become worse with COVID.
Thank you for that. Now, Daniel Chang, you've been doing a lot of reporting on how these medications are making their way from the federal government to states and then from states to healthcare providers. Can you explain that system briefly? And respond to some of what we were just hearing from Aaron. How are these issues playing out in Florida?
So as Murphy's Law would have it, my neighbor just fired up his leaf blower, and I apologize if it's a little loud from my end. It should end soon. It's not a big yard. But to explain, yes, the federal government controls the supply. Basically, it bought up, just like it did with the vaccines, most of what was available for monoclonal antibodies, and has done the same with the antivirals. And although the test and treat program would allow pharmacists to directly order from HHS, that's another sort of new feature of that plan. But the way it works right now is that the federal government distributes them to the states, usually a Department of Health or Department of Emergency Services. And then from the state level, it gets distributed down to providers. And the states are very different in terms of how they prioritize distribution of these new drugs. For instance, back in right around Christmas time, when Evusheld, which is a pre-exposure prophylaxis, a monoclonal antibody that was designed specifically for people with weak immune systems who cannot develop a immune response to the vaccine due to active cancer treatment or HIV or other chronic illnesses. But the first dose went to a small concierge clinic that basically made house calls and did COVID testing at private parties. And it wasn't clear why the state had bypassed our big transplant hospitals. Miami has the largest transplant hospital in the southeastern United States. We have lots of cancer centers. And in reaching out to the Department of Health, they told us that they didn't really have a plan to prioritize these individuals, but they did reverse course after our reporting and said that they would prioritize those specific hospitals for it. So that's kind of a long-winded way to say that it's really up to the states, your state officials, to determine where it goes locally. And in terms of what Aaron was talking about test to treat, everything that he said is absolutely true. And as we saw, the White House issued a press release yesterday saying that its plan was now in jeopardy because Congress had not agreed to fund the COVID response needs. So I think it remains to be seen where that ends up. So that's.
So as you said, states, it's up to states to figure out how they're going to distribute these, allocate these, ration these in their own states. There's been a lot of discussion and some controversy about whether race and ethnicity, poverty should be taken into account when prioritizing distribution. A couple of states that initially considered putting considered adding race to list of criteria back down under the threats of lawsuit. Aaron, can you speak to that and how states are and can ensure equity without explicitly considering race and ethnicity?
I mean, what I think they're trying to do is explicitly consider risk factors. And unfortunately, in the United States, race is a risk factor. Because it is not that they are trying to unfairly elevate some underrepresented minorities for treatment. They're trying to address already existing inequities and racism in the system. And that often requires a reprioritization of an already tilted system, which unfortunately isn't headed in the right direction. We know it will be harder and more difficult for many people to receive these drugs than others. And one of the things, and that is a marker for whether that will be, is race or ethnicity. I wish that weren't so. I wish we had a system where that wasn't so, but it is. There's no question that that'll be used for political arguments and grist for the mill of fights that people want to have. But I think trying to continue to couch this in the language of we're prioritizing certain risk factors and ways that we can identify people at higher risk will go a lot farther than calling it prioritizing by race.
And Annie, how do you address those in San Francisco?
Well, I just want to make a comment about, when the monoclonals first came out, and I think it's still even included in the package language, they did prioritize race and ethnicity as a risk factor. And it still didn't help us get more of the agents to where they needed to go, as you referenced that MMWR that showed the disparities that we saw in Hispanics and Black Americans. So even when we do use that language isn't sufficient to overcome those barriers. So you can't overstate the baked in, I think, as Aaron used that terminology, disparities that are being exposed by COVID in our system. And it's really hard to get all the stars to align. It's hard enough for people when they already have, insurance and everything lined up to figure out how to get tested, get in touch with a prescriber, get this all done within 5 days. And if there's more disparities there, it just makes it increasingly challenged. And I think we saw just how much communities of color, unfortunately, were disproportionately impacted. And I think we're gonna have to do a lot of extra work to try to make sure we're not continuing there, because it's been really heartbreaking to see how much communities have suffered.
And are there specific things that need to happen short of, I mean, obviously there are huge changes in the healthcare system, but we have an emergency, we have needs right now. How do we reconcile those two things?
Well, I mean, I think it's a two-part thing, and it looks like Aaron may have something that he wants to say, but I think that there's two parts. I think messaging and information to all different communities has become increasingly important. And I think we've recognized that through COVID. And so making sure that people are aware that there are treatments and that they understand what they mean, and that any misinformation that may be accompanying, vaccination or treatment, that is appropriately addressed. And that we've understood that this is more effective if it's delivered within the context of the community. So being really thoughtful about how we share our messaging and the language, and that any advertising or patient information includes the populations, and that they've had a chance to weigh in on this, so to understand, hey, that this looks like me, you're speaking to me, these are my concerns, and this is coming from providers that I trust and I understand. That's incredibly important. So that's one piece, understanding, what community needs are and what people have heard, and who trusted advisors are in those communities. But the other piece is just the structural one, that there's a lot of work that we need to do to break down barriers in quick access. But it can be done. And I just want to point out, one thing that San Francisco has really focused on outside of COVID is making sure that people with HIV, are started on therapy immediately after testing positive. And that means like within a day. And when this whole concept first came up, people just said that's not possible. I mean, just forget it. It's too hard, and insurance and barriers, and people who are getting HIV may already be more outside of the system. And all of those things are true. And all this has by and large been able to be done. So these things can be done. It just requires the recognizing that there's a problem, and then the will to try to address it further.
And Aaron, it looked like you wanted to say something.
I do. One of the biggest disappointments of this pandemic has been our failure of imagination, and like our inability to try to find new ways to do things. Just rattling off just ideas. We could have physicians today identify any patients who are at risk and would qualify for therapy should they come down with COVID. We could distribute pills to them right now. We could also, along with that, distribute antigen tests to them. Tell them if they're symptomatic, take the test. If it's positive, start the medication. And that way, anyone who might become positive will become positive. That'll miss people who don't have regular health care. So go into the communities. There was a phenomenal trial a number of years ago where they placed pharmacists in African-American barbershops and managed hypertension and high blood pressure there by going to where people are, as opposed to making them come to you. We could find community sites like that to do this distribution, to reach the communities that we might not otherwise reach, so that people would have the therapy on hand if and when they become positive, and the means to test themselves. We don't do any of that. We keep trying to shoehorn this into the already existing and equitable healthcare system that nobody loves to begin with. And that's not going to get us where we need to be.
So one issue that's come up a lot is pharmacists and whether pharmacists should be able to prescribe these drugs, make them available quickly. I know you have reported on this, Dan, and there's been pushback from the medical community. Is there a turf war? Are there legitimate concerns about changing how?
I think the doctors would probably be better suited to address this question, but there's always, I think, a concern about what they call scope creep. So extension of your scope of practice. And, physicians' assistants and registered nurses have tried for years in Florida to get the ability to see patients and to prescribe drugs. And it's been opposed. In large part, you saw the American Medical Association issue a statement not long after the test to treat program was announced, saying that they didn't think it was a good idea, that even though pharmacists in many states have the ability to test to treat for specific conditions like strep throat and the flu, the AMA was opposed to it. They said something like, COVID-19 is a complicated disease, it's not strep throat. So they're clearly opposed to it, and they're a very influential group. But what Aaron and what Annie were saying about the need to treat quickly and early in the disease in order for these drugs to have the most effect is really what we're trying to get at. And just to their points, if we keep doing things the way we have been doing, first come, first served, let's send it to places where there's the most cases or deaths, you're not going to make a difference. You need to acknowledge that these disparities exist and try something different to address it. And there has been failure of imagination, in my opinion, along those lines, both in Florida and on the national level. We just keep doing things the way we've always been doing and expecting a different outcome.
And Annie, I wonder if you can address the issue of pharmacists, what you see from where you sit as a physician and what you hear from pharmacists that you work with at UCSF and San Francisco General.
Yeah, I mean, I would say, first of all, pharmacists are incredibly valued resources that, medical providers are thrilled to work with. And I think pharmacists have taken on an enormous amount of work. First of all, they do an enormous amount of work in general, but boy, the burden of a lot of the testing and vaccination, we've increasingly seen shifted. And I think it's a great idea to use pharmacies to do testing and vaccination. I think we have to think through what pharmacists want to and feel capable of doing. And as I mentioned with Pexlobin, that in particular is a drug that is a little tricky. And not only do you have to go through all the drug-drug interactions, which pharmacists can do, but you have to have all that list. I mean, one of the challenges that we have is if someone's not engaged in medical care, they're kind of getting it all over the place, is how do you even know what people are taking? Half the time people aren't quite sure what they're taking. And it's that blue pill and the red one for my high blood pressure. I mean, that's what my parents say to me when I try and get the list of meds that they're on. So it's not uncommon for people not to know that. I also just want to raise the point that I don't know that there's going to be a one-size-fits-all solution and that we shouldn't try to have those. There may be settings where pharmacists want to do this and it fits in their scope of practice, and in other settings where that this is not going to fit for them. And I think the pharmacy, even if every pharmacist was able to do this and the laws change, this isn't going to solve our problems. It's going to be part of the solution. So I want us to continue to think of multiple ways to solve this access issue, including pharmacies, but not limited there. I think we have to get medications to the sites where testing is happening and then figure out a way for people to quickly get the medications. It's just not possible to talk to your doctor about this. What you hear at the end of every ad, that is not going to happen. And it's just the timing required is just going to be too challenging. Yes, in some circumstances it can be, but we're just going to have to continue to be creative and thoughtful here. So I think pharmacists absolutely can be part of the solution here, whether or not it leads to them actually prescribing Paxlovid, but I think there might be some barriers to that. But some of the other medicines, sorry, there's an ambulance going by. Some of the other medicines might be feasible, but I think we have to really recognize that if that's where people are getting tested, wherever people are getting tested, we want the drug to be right there as close as it can possibly be, because otherwise we're going to be behind the 8 ball here.
I want to switch gears for a minute and talk about the needs of patients who have immune compromised conditions, immunosuppressed patients, and prophylactic treatment. Erin, you recently wrote about some of this in the New York Times. There's a lot of concern among people who either are not eligible for the vaccine or who don't respond all that well to the vaccine about the fact that we're losing masks, we're letting go of all kinds of COVID precautions. And at the same time, there have been news reports that medication that can be a preventive for these patients is sitting on the shelves unused. Erin, can you tell us what's going on there?
Yeah, I hate to be the super pessimist all the time, but America has never done the right thing by the immunocompromised. This COVID once again has exposed our indifference, not necessarily caused it, and certainly exacerbated it. It wasn't as if, during flu season in the past, we couldn't get more than 50-60% of people ever to get a flu shot, even though that's how we protect those who can't protect themselves. That's why we do all vaccinations for the most part. I mean, some of it is a benefit to you, but a lot of it is to protect those who can't protect themselves. One of my really good friends was diagnosed with cancer a couple of years ago. I couldn't even get most of my friends to get vaccinated to protect him. His wife's a teacher. They certainly made no accommodations because she was living with someone who's immunocompromised. His kids were in school. They weren't going to make any kind of accommodations in the classroom because one of them can get sick and bring it home and be a risk to him. We have lots of kids in school with cancer right now. We don't make these kinds of accommodations. We don't do good sick leave. We don't have phenomenal family leave policies to care for them. We're just not set up for this. And the idea that on a dime, we're all going to be able to flip a switch and now all of a sudden, without any kind of big infrastructure, start acting that way is almost too heavy a lift. And we're finding it's not working, and that lots of people who are at real risk and very concerned are really upset that many people are like, well, let's just go back to normal when this big risk exists out there. I wish there was more of a sense of shared sacrifice and community, but I also wish that we would, have policies that acknowledge and provide people the resources to protect themselves and those they love when they are at higher risk and immunocompromised. And we have never had that throughout this pandemic, and we really haven't had it before then, and it would take major shifts in policy for us to get those.
How effective is prophylactic treatment? Annie?
Well, go ahead.
Well, yeah. So it's evolving. The data that we have for Evusheld weren't by and large it wasn't in vaccinated population, and it wasn't in a highly immunocompromised population. Nonetheless, it makes sense to use. It's been safe, and it does have an emergency use authorization. So we are still learning a lot about this and what it will look like in the populations that we're using it in. It does make good sense to give medicines like Evusheld, though. We have a lot of kidney transplant, liver transplant, cancer patients, people who are on immunosuppressing medications. And what we do know is that the vaccines just don't work as well in them. They should get vaccinated, and vaccination may help to reduce the risk, but it's been clear that it is not sufficient, that they still remain at higher risk depending on what medications they are on. They're also looking into oral therapies for prophylaxis, which would be a lot easier to do. But right now, taking an IV infusion, or it's actually an intramuscular injection once every 6 months is not terrible as at least an alternative. And Erin, one of the other comments that I would just make is that I completely agree with you about immunocompromised. And I feel like that's sort of been a shadow group that our society really hasn't addressed very well, and Americans are sort of doing it for themselves. But one thing that gives me hope with COVID is we saw the enormous impact that this disease had on people who are older, and that really one of the biggest risk factors still is being elderly. And I think everybody could get their head around, I want to help protect my older relative. I want to protect grandma, even if this disease my risk is lower. I care about the people who are older in my life. And I'm really hoping that we can try to extend that to recognizing the sort of shadow population of people living with immunocompromising conditions that in general we've had a harder time doing.
So Dan, you did some great reporting on Evusheld, and as you mentioned, the fact that it was going to this concierge clinic and not going to this major transplant center in the region. And one thing that really struck me in your reporting was that the Florida Health Department wouldn't tell you how they prioritize their supplies and their distribution. And yet you were able to trace where things were going nonetheless. Can you just quickly walk through how you did the reporting on that?
Yeah, of course. So when Every Show first came out, HHS had a website that I think has since been updated that showed you where these therapeutics were going by state and by therapeutic. And one of the things that we had noticed and I had written to the health department to ask about after a reader contacted me was how come Every Show was going to this little known clinic in South Florida. And, you know, all I had to do was go to that website to see where it had gone. And this was very early in the distribution. I don't think it started getting distributed Every Show until about December, right around the time that Omicron was starting to pick up, which is another thing that we ought to talk about, which is the effect of variants on these therapeutics. But after this reader contacted me, I reached out to the Department of Health. I discovered that they were basically using a list of hospitals and healthcare facilities in the state and going down and calling them saying, hey, do you want this? And can you carry it? It just seemed to me there has to be a better way than that. You know, you have to know at least who this drug is designed for, who the sort of target audience is, if you will, or target patient. And they weren't even using that, which was a little discouraging. Talking to folks who deal, bioethicists and folks who deal with how you distribute scarce resources and prioritize individuals for it, all told me that there was no plan here, really. This is just sort of first come, first served, and you're not going to get this to the people who really need it. So it was pretty apparent, and the information was there from the federal government. The hardest part was just trying to get the state to explain what they were doing and what reasoning or what strategy they had to try to get this to the people who clearly needed it most. And after a while, it became apparent that that wasn't there. So,
yeah, thank you. So we have a lot of questions coming in before we get to.
Can I just say one thing?
Yes,
I didn't
please.
answer your. I do want to give you one data point, which is just for the Evusheld PREVENT study. It was about an 80% reduction in symptomatic COVID at 6 months. So people who had been dosed. There were some differences probably with how we're rolling it out now, but again, I think it was a pretty marked reduction in symptomatic COVID disease for higher risk populations. So
That's
didn't want to leave without making that comment.
Yeah, thank you. Thank you for adding that. So reminder, put your questions in the Q&A box. And before we move to our audience questions, I'd like to ask each of you, I'll ask Dan, what stories are you looking at? And then I'd like to ask our doctors and experts, what stories do you think reporters should be looking at in the next weeks and months ahead? Dan, why don't you take it first?
As it relates to COVID-19 therapeutics, I think we need to find out how the White House's plan is going to be funded. I think that's probably the most immediate question. But I think that there still continues to be challenges with testing as well, even though the White House and federal government has shipped lots of rapid antigen tests. I think that the infrastructure in a lot of places has been taken down for people who want to go somewhere and get it for free. Maybe they weren't able to, or didn't get it from the federal government. I think testing is still going to be a problem. And so those are the sort of immediate things that I'm looking at right now. And certainly there's lots of research taking place and development of potential COVID-19 therapeutics. And then, of course, we have to wonder about the end of the public health emergency, which wouldn't probably happen before July, but all of these drugs that are authorized under emergency use will suddenly lose their authorization. And I'm not sure what the backup plan is for when that happens.
Annie?
Yeah, I was just thinking how valuable journalism is to provide the nuance and the color commentary when our society completely understandably just wants a black and white answer. I mean, the question I'm asked all the time is this over? Is this over? Is this over? Right? And I know that we all desperately want this to be over, but I think that the reality is, now that we've come out of our probably 5th wave here, is that we are going to have some COVID in our lives in some way as waves continue. We've made a huge amount of progress. I'm an optimist. I think that this doesn't mean doom and gloom, but I think that the really great reporting that I've seen has helped people contextualize this, and I'd encourage all the excellent journalists here to continue to do that. So to contextualize, will I never wear a mask again? No, the metaphor is a mask is like an umbrella, right? People have talked about that. You don't wear it when it's not raining, but we're going to need masks, and many societies have used masks a lot more, such as in influenza, and that it's okay to have a nuanced approach to this. I think there's been great reporting on mild COVID, when I think that with Omicron, there was a lot of optimism about how much less severe the disease was, but the mild disease is still really destructive for people who are suffering from symptoms and for our society. You can't go to work, your daycare is impacted. And when everyone has tried to be very black and white and say, Omicron, no problem, it's mild, I think that's where journalism can help to reflect what the bigger impacts are there. So thank you for providing that nuance and digging a little bit deeper, because I think that's really been extraordinarily helpful when everyone is looking for a very black and white solution.
I'll add that I think we need still a massive focus on fixing the infrastructure and making sure we're ready for the next time. Whether it's COVID, another surge, or another pandemic, this will not be the last type of emergency we face. We were absolutely unequipped and unprepared for this one. I'm still not convinced we're prepared for the next one. And while we're all still remembering how bad this was and how bad it might get, we need to make sure that we invest and not put our heads back in the sand and hope that this doesn't happen again.
And I would say to that, Aaron, too, that there's this sort of COVID exceptionalism, right? That this is this one bad thing that happened, and let's have it be over and just forget about it. I mean, the truth is that people have been talking about a coronavirus or an influenza pandemic. We've been waiting for it. We still are waiting for influenza, to shift into something that's worrisome, and that this absolutely is an opportunity for us to remember this and not just say, great, I threw my mask in the garbage, I never want to think about it again, because we're going to face these challenges and we can face them, but we do a pretty lousy job at preparedness. I think this is what is shared with us.
Okay, so we are going to turn this over. We have a bunch of great questions from the audience. So we have a question. Are you aware of discussions around including long COVID as a risk factor, making people eligible for these medications if they're reinfected?
The short answer is no. I mean, there's absolutely great research going on in long COVID. I don't think that we have data to suggest that if someone had long COVID and gets reinfected, that they should be more or less eligible for treatment. I do think we undertreat people, and I think that many qualify for therapy who have no idea or who aren't able to access it. So I certainly think we need to do a better job there. And I think that the whole field of long COVID is really fascinating. And I think we're going to learn a lot more about that with some really exciting research initiatives that are ongoing. We don't have good treatments for long COVID yet, in part because we don't have a great understanding of what drives it. But I'm optimistic that that's an area that's going to change.
Okay, we have a question from Marga Arroyo from a paper in San Juan, Puerto Rico. I'd like to know your thoughts on the possible approval of another booster vaccine, fourth dose. The World Health Organization has reported there are underdeveloped countries still facing challenges to access. At the same time, we've seen these spikes in Europe, and we're hearing conversations from the drug manufacturers about this. What's on the horizon?
Well, first of all, I really wish we would get out of the habit of numbering these things. When I get my flu shot every fall, I don't roll my eyes and say, this is my 50th booster of the flu shot. I get my yearly flu shot. At some point, we will probably either have an understanding that we've had enough COVID shots, or we may need them periodically, say every year, and maybe someday it'll be the yearly COVID/flu shot. I don't know. But But I do think that everybody is worrying a lot about this. The antibody levels do seem to drop after you get each booster shot, but most of the data that I've seen so far would argue that after the third shot, cellular immunity is still pretty good at preventing hospitalization and death and other bad outcomes, which is really what we do care about. The news that I see about a fourth shot almost comes entirely from, it seems, Pfizer or Moderna. And I would always say, recognize there's a conflict of interest there. And that's why we need other groups to tell us whether or not we should get those doses. It's possible that for high-risk people, we may need additional boosters. It's possible we might not. It's possible it might be longer from now. We just don't know. But if you've been boosted, you're pretty safe as things go. And especially as this report is bringing up, the vast inequity of distribution of vaccines across the world. Now, if a vaccine is sitting on a shelf in the United States, it's unlikely to go somewhere else. And so I understand the argument of using it if we have it. But understanding that there are many places that truly need first or second doses of this makes it somewhat problematic to keep pushing for even more doses in the United States when we don't really have good data that shows it's preventing bad, that's necessary to prevent a lot of bad outcomes. If our goal is to prevent cases, we're going to be boostering often and forever because antibodies will wane always after each dose. So it depends on what our goal is, where the data is, and what's going on. But I do appreciate and echo that we need to be thinking about, everyone and equity around here as well.
So Annie, I know you've studied the use of telemedicine for hepatitis and adherence to treatment, and I'm wondering if telemedicine will offer some solution to some of the hurdles that we're seeing, and whether you, either in San Francisco or around the country, are seeing innovative uses of telemedicine to get around some of these obstacles.
Yeah, so I'm glad you brought up hepatitis C, because I think it really is a cautionary tale. Hepatitis C, we had no treatment for a long time and now have great treatment, right? You can treat and cure 99% of people in 3 months or less with well-tolerated all oral therapy. For a long time, we said, that's all we want. We just want the pills that work, right? Now we have them, and we're still doing a pretty terrible job of testing people, making sure they're aware they have hepatitis, getting them the therapy they need, and keeping them and then keeping them cured, right? Having the drugs alone isn't enough. We need the drugs. We needed these medications for COVID. We have some pretty good medications for COVID, but we have to learn from hepatitis that just having the medications is necessary but not sufficient. So what we have learned from the hepatitis world is that we need to go further and figure out where are people living with Hep C. There are a lot of more vulnerable and marginalized communities who aren't coming to their doctor on a daily basis and demanding their Hep C medicines. So things like telemedicine have been really helpful. Project ECHO has done a really terrific job of reaching providers and getting them up to speed. We've realized in hepatitis C, you don't need to be an expert. You don't need to be a hepatologist or an infectious disease doctor to treat people. So, and telemedicine is another way to really leverage that. You can not only get support for the provider, but then also reach the patients. So I think there's a lot of lessons that we can learn and some cautionary tales from hepatitis C as well. I hope we are able to respond more quickly and reach more people than we have with hepatitis C. I think telemedicine is a great option. It gets you part of the way there. You need to have a provider on the other end. There needs to be a way to have that infrastructure. And then you need to be able to reach the people who have just been diagnosed. And so I think we need to be creative about that. But there are examples. I think New York City is using telemedicine to try to get medications out. And as I understand it, I'm not based there, but that they've done well. And we're trying to ramp up our efforts here as well to really leverage telemedicine. Because again, as Aaron pointed out, having someone come in to see their doctor. First of all, the doctor doesn't want to see you when you have active COVID. In the office, if you're sick, you should go to the emergency room for sure. But there are a lot of barriers that are there. So trying to make this as easy as possible while being sure that you're safely able to prescribe the medicines is going to be one of the things to allow us to thread the needle. And again, typically we haven't done a great job of this, but the tools are there for us to leverage, and telemedicine is one of them.
We have a question from a journalist. Is there any data or are there any studies that suggest that using these treatments in a timely fashion can reduce the chance of developing long COVID?
It's sort of the one of the $1 million questions. A lot of these medications are new, and long COVID by definition takes time to diagnose, because you want to make sure that people haven't just had a slow time to resolve their symptoms. So we don't know is the bottom line, but we very much would like to find out. And many of these studies are extended so that they can evaluate people for long COVID. It does stand to reason from other viral diseases that the sooner you treat people and get them feeling better, the less opportunity you have to create damage to the body and to set up immunologic problems and inflammatory problems. So it stands to reason, but we don't have that data yet.
And we have a follow-up question for Dr. Carroll. Why should we be looking for others besides Pfizer, Moderna for another booster?
So I don't mean that we should be looking at other companies to answer. I just mean if I ask Pfizer if people should get a fourth Pfizer shot, the CEO is probably going to say yes, because they're financially conflicted. So I just mean that I probably wouldn't ask, the seller of the product if we should buy more. We need like dispassionate third party, scientific experts to sort of go over the data and determine if people should get another booster. But most of the news stories I see say in interview or panel or something with CEO of company, they say that we should get a fourth booster.
Okay, so just a little bit off the drug topic. I saw a tweet that you had this week, I think, Aaron, as we hit the 2-year mark of shutting down, and it was a response that you had to the New York Times, an invitation to write a column about why should we be making a big fuss about this infection of these pneumonias over in China. Just wonder if you could just tell us.
Yeah, I mean, it was just remarkable, because I mean, if my sort of wheelhouse has always been writing often about how we're too worried, we're too panicked, where that there are some things that we hear that we should do because it's going to save our life, and a lot of that is overestimated. It's often relative risk, not absolute risk, and it can get very confusing. But one of my editors, and I love my editors, don't get me wrong, wrote and said, they're talking about whether we should shelter in place, and people are concerned that could get lonely and isolating. And would you be interested in writing a piece on how like this could have real downsides? And I just remember writing back, and I was like, this is the first time I think I've ever turned down the opportunity to write a column. Like, I was like, no. If anything, I think we're underestimating the problem. That we've only done like 2,000 tests in the United States. We have way less hospital ICU and ventilator capacity than we might think. Hospitals in Italy and soon Spain were about to be overwhelmed, and it was very easy to see that could happen really quickly in the United States. And to their credit, they let me write that up instead. And it wasn't, everybody was sort of coalescing on this. The difference between like being early and being late felt like 2 weeks, because it was only about 2 weeks later the country felt like it was in lockdown. And I am impressed at how quickly we actually responded. Like, if you'd told me weeks earlier that Americans would shelter in place as quickly and as much as they did, I would not have believed it. But it's still, when I look back at that email, it strikes me at how we just did not see this coming. I mean, some people did, let's give them credit. But a lot of, a lot of people just did not see this coming as it started to ramp up in China and get overseas. And I'm really concerned, as I said before, that we won't see it coming again.
Well, on that note, we are out of time, and this has been a fabulous discussion. I want to give, on behalf of the Center for Health Journalism, a sincere thanks to Annie, Aaron, and Dan, and to the audience for your great questions. We'll be sending the audience a survey asking for your feedback on today's program and for your ideas on other topics of interest. So please take a moment to complete it. And we urge you to help support these webinars. You can find more information here on how to do that. Again, we're archiving this webinar a little later today at centerforhealthjournalism.org. Thank you so much for joining us, and have a wonderful day.